So no, sorry for that. Well,
Okay.
yeah. Okay. So it's 5 o'clock now, and we're launching our 15th fetal webinar from the Congenital Heart Academy. I'd like to welcome Sasha Agati and Grace van Leeuwen. So they are the really the important people to run the Congenital Heart Academy series. I'd like to welcome our mentor and everlasting boss, Dr. Silverman. And I'd like to introduce myself. I'm Dr. Rima Bader, Professor of Pediatric and Fetal Cardiology, running the Fetal Series. Today, it's a really special day, and we're very grateful to our two invited consultants from London, UK, and they're going to teach us the basics and the advanced sort of points in the fetal cardiac MRI. If you'd allow me to introduce our first speaker, Dr. David Lloyd is a consultant pediatric and fetal cardiologist at Evelina Children's Hospital. Before it used to be Guy's Hospital. He is a long sort of bio. He was involved in research and also MRI and special interest in fetal cardiac MRI in pregnancy, and he and his colleague, Dr. Pish Barja, also done quite a lot of publications. So, and if you'd allow me, David, could you please go on? We have 30 minutes for David to teach us on fetal cardiac MRI. Thank you.
Thank you very much. I'll just quickly share my slides. Hopefully you can see that coming up. Oh, that's not the first slide. Let's start at the beginning.
David wanted to do polls on some questions, but unfortunately, Dr. Agati is not around. He's a surgeon and he has an emergency. So what we decided is that you sort of read the questions and think of the answers and compare your questions before the talk and after the talk. It's sort of an introduction to how we deal with fetal cardiac MRI. Is this okay, David?
Yeah, that's absolutely fine. So, I mean, I think what we were going to do is if we could ask for a little poll of, well, who's doing fetal cardiac MRI in their centers, but more what people's first impressions when they hear fetal cardiac MRI, is that something they think is useful, is clinically useful, and has a place in our practice. So perhaps I'd like you to just sort of think of your immediate answer to that question, and then that's something we can think about after you've heard both of our talks. So myself and Kubiran are both based in London in the UK. This is where we are on the left, St Thomas's Hospital, very close to Big Ben and Houses of Parliament on the other side of the river. And then just the kind of nomenclature of where we work. So Guy's and St Thomas's is the trust, that's St Thomas's Hospital. Guy's is based over in London Bridge. And Evelina London is the Children's Hospital, which we both work at, which is on site. And King's College London is our university partner, and they have a campus actually set up in the hospital. So we're very well integrated with our academic and engineering and physicist colleagues. So we decided to split the two talks up. Obviously, we're based at the same center and we run the same program. And we run a research program, which has been established really since 2014. And now we run a very well-established clinical program. And what I was going to talk about is perhaps some just overview of the technical advances from a more sort of technical perspective in terms of what we can now do with fetal cardiac MRI and some of the issues with that. And then Kubiran's going to really focus on the clinical uses and utility of fetal cardiac MRI and MRI in general in fetal life. So fetal cardiac MRI has had a really rapid development, I think, over the last 5 or 10 years. And it's something which has been relatively bespoke, and different centers have picked up different methods and approached the problems of fetal imaging in different ways. So it's still pretty heterogeneous, and it's still a very new area. And I think because of that, you find that the sort of infrastructure, what people are doing, and even how they're using it clinically are very much center dependent. And basically, it's still an emerging technology, and I think that causes a lot of differences in how people practice, but also is very exciting world to be a part of. So in this talk, I'm just going to give you a sort of really very brief overview of why we might need fetal CMR in the first place. What potential roles could it serve? And then an overview of the technical challenges of using MRI to image the fetal heart before birth. And then I'm going to talk through some of the approaches and solutions in our center, but also some solutions which have been devised elsewhere. And then a little bit about sort of future work streams and where we might be in the future with fetal cardiac MRI. So I think this is probably very familiar to many of the people on the call, but it's really just to sort of say that if you think about fetal diagnosis of congenital heart disease, it's very reliant on fetal echocardiography, and the standard views that we use are in all the textbooks, which are generally two-dimensional views of the fetal heart, and have been established with that technology for several decades. And there is certainly three-dimensional technology with ultrasound. I think it's fair to say it hasn't had hugely wide uptake, and really the mainstay of diagnosis is two-dimensional fetal echocardiography. So what if we need more information? And obviously that scenario is very common in postnatal life. We do an ultrasound scan or an echocardiogram, and we say we just need a little bit more information here, either anatomically, physiologically, something to help guide us in terms of what's happening in this particular patient. And we're very familiar, obviously, postnatally, we have CT and contrast enhanced CT and various other methods using X-rays we can't use in pregnancy. And we're very familiar with postnatal cardiac MRI and the fully fledged, very detailed type of anatomical physiological study you can get from that when we ask our patients to hold our breath and do a gated cine over multiple cardiac cycles, high resolution, three-dimensional imaging and volumetric data of the heart and the ventricles, phase contrast flow to measure flow in the great vessels, and intravenous contrast to give us great anatomical imaging of the vasculature. And I think it's pretty obvious that pretty much all of these things in front of you are going to be very limited in fetal life. And so specifically, if you look at some of the issues, so obviously the fetal heart is very small, and even at, well, we do most of our scanning at sort of 30, 32 weeks, and we're still talking about an ascending aorta diameter of somewhere around 6 millimeters, as you can see on that chart on the right-hand side there. So the fetal heart is very, very small. And when you're talking about resolution, which is one of the big trade-offs in any kind of scan with MRI, in terms of the time of scanning and the resolution we want, this is going to be technically very challenging. And of course, the fetal heart is beating, and it's beating quickly. It's beating, up to 130, 140 beats per minute. And then probably, I think, to my mind, the biggest challenge of fetal cardiac MRI is the motion of the fetus itself. And this is actually an MRI cine of a fetus, and just demonstrating to you the capabilities of a baby in the womb and how much they can move during an acquisition. And if you imagine we're trying to plan a single two-dimensional plane through the fetal heart at a 4-chamber view, you can imagine how difficult this is going to be with MRI. So just to summarize those things, the fetal heart is very small. It's set inside the maternal abdomen, which is much larger relative to the heart, which is the bit we're interested in. Maternal and fetal motion, even if the mother can stay still, there's still breathing movements which transmit to the abdomen. We can only ask for so many breath holds in mothers, and in fact, in our pipelines, we don't ask for any breath holds at all. Fetal cardiac motion. And then there's also, which I won't go into huge detail about, the issue of safety. And I think that's pretty well established that MRI is a safe technology, provided that it's used within standard limits in terms of acoustic noise with the sequences you use, and for radiofrequency deposition, i.e. within normal mode limits with MRI. And certainly all of the work that we do in St. Thomas's is well within those safety limits. Okay, so this is basically the overview of some of the approaches I'm going to talk about. So I'm going to go through each of these individually, and I'm going to start with, I think, which is probably the earliest sort of sequences people used that really got traction, which was single shot 2D sequences. And essentially these types of sequences are a single plane planned through the fetal heart in whatever orientation you wish, and designed to be fast. So you're freezing fetal motion and potentially cardiac motion in a single shot. Two major types of contrast used with that. This is a balanced sequence. So this is a sequence which essentially gives us like a bright blood contrast. So you can see here, this is a transverse view through the fetal chest And you can see the left and right ventricles here, for example. This is a case with an outpouching of the right ventricle, but I'll leave Kibiran to talk through some of the more clinical implications of this type of imaging a little bit later on. And then the other type of contrast is single shot fast spin echo, which gives more of a black blood. So the signal's washed out by moving blood. And then you get this very high contrast between the blood pool, which is black in these images, and the surrounding tissues, such as the thymus and the lung. So this could be potentially a little bit better for looking at the vasculature. You don't get any contrast inside the heart with this. The heart will just look like a kind of black sphere or black blob. But this is kind of the earlier sort of explorations of that. The issue with this is if you don't hit what you're looking for in that single shot, you may even acquire a stack of shots like in this data, but you don't have any three-dimensional information. And even contiguous slices, as in the stack of data, you can see with minimal fetal and maternal motion, this is uninterpretable in any other direction other than the 2D plane in which you planned it. So there's a lot of hit and miss in this, and certainly in our experience, acquiring these types of stacks of sequences over and over again, you may have one or two images which showed you something potentially diagnostic out of maybe hundreds of other images that you acquired trying to chase this fetus around. So very inefficient way of scanning and difficult, and actually a reasonably high failure rate. So in our initial experience, we probably had no usable data in sort of 15% of cases. So that leads on to 3D motion correction. So what can we do with that information to try and give a more detailed overview of what we want to see? And this is some work actually from colleagues in King's College London and our university partner, Maria Deprez and Bernard Kynes. And this was initially established for the fetal brain as a rigid organ, so this doesn't necessarily change shape in the fetus, not in the same way perhaps that the heart might. But if you have overlapping stacks of the type I've just shown you in multiple different orientations, essentially the region of interest, in this case, the brain, is represented in each of those images, albeit very mixed up due to the fetal motion that you would have had during the acquisition. But these algorithms, and these are post-processing algorithms, can essentially take those overlapping data, mask out a region, perhaps in a good stack where there's not too much motion, and then start registering all the data from all the other stacks to that particular region of interest. And from that, you can build a three-dimensional image, which is, if you like, separated out from the surrounding tissues, which may involve fetal motion or maternal breathing. And this is an example of what that looks like. This is a minimum intensity projection of a reconstructed volume of the fetal chest, just to show what that potentially looks like. And you obviously can navigate that in 3 dimensions. And you can segment out the blood pool from that and the lungs in this case. So we're looking from the posterior aspect of the chest here. You've got the right lung on the right, left lung on the left. And if I remove those, hopefully they'll disappear in just a second. And then you can see in yellow here, this is a case with anomalous pulmonary veins going to the IVC on the right, which is in blue. So you can actually get quite detailed 3-dimensional information from these data, all constructed from those original 2D input stacks. So we actually prospectively then in our center started recruiting, with the help of our clinical colleagues in fetal cardiology, an initial cohort of 85 patients carrying a fetus with congenital heart disease, and went through a process of really validating this 3D reconstruction technique for the fetal chest. And this actually gave very good results. So this is paired echocardiograms, and you can see on the left, we're looking at vascular measurements here, just of various different vessels within the around the fetal heart. And we're looking at intra-observer variability here on echocardiography on the left, and then an MRI between 2 observers on the right. And you can see that in terms of intra-observer variability, compares very favorably to MRI, to echo. And also we compared, just looking at 4 major categories of fetal vasculature, you can see on the left. We compared essentially just how well you could see things. So the pink bars here are just the 2-dimensional MRI acquired in the way that I described. So looking at these multiple stacks, someone poring over those, seeing if they could identify each of these structures, and then compared to the 3-dimensional volume. And you can see that essentially observers did very well in identifying the structures of interest with these 3-dimensional data sets. So this potentially looked very, very useful, relatively reliable, and actually, the other bit that's not necessarily in this slide is to say that in pretty much every case that went through, we could generate these data sets. So it was reliable in the sense that it was very robust, and actually generally we were able to produce these 3D data sets in pretty much any woman who came through the scanner, albeit with the caveat that that is somewhere between 30 and 34 weeks gestation. And this is just an example, just a single example, but I think Iberian will give you several more. On the left, we've got an image from the posteriorly. This is a fetal motion-corrected MRI at 32 weeks gestation, pulmonary atresia, VSD with major aortopulmonary collateral arteries. From the posterior aspect, this is a right aortic arch. There's an aberrant left subclavian artery. There's a lot going on here in this diagnosis. It's a complex diagnosis, and certainly complex to understand just simply from two-dimensional echo images. This is our image on the left for motion-corrected MRI, and on the right you can see the postnatal contrast-enhanced CT. So essentially a method which is very reliable for the vessels. We're not seeing any information about the inside of the heart here, and potentially brings some of that postnatal imaging where you'd have to wait until the baby is delivered so that they can undergo these types of investigation, brings that into the prenatal realm. So you can counsel, you can plan, and in fact, for this specific case, this family even met with our surgical colleagues, and they gave them an overview of their surgical approach. Okay, so moving on from there. So what I haven't talked about in any of those images is how you might gate for the heart in fetal life. Obviously, postnatally, we would just simply put some ECG stickers on, and that would interface directly with our MRI scanner, and then we can acquire data at any point in the cardiac cycle that we wish. But that obviously presents a very significant technical challenge in fetal life. So the first approach, and really the first approach that was really put out there to address this, is a technique called metric optimized gating. And this was developed by Mike Seed and Chris McGowan and the team in Sick Kids in Toronto. And essentially just a sort of very basic overview of how that works is you acquire kind of agnostically. So you acquire actually with an artificially low heart rate. So you essentially over acquiring per cardiac cycle, whatever data that you wish. And then you use metric optimized gating, which essentially gates that data iteratively at varying heart rates until it gets an ordered response, if you like, based on a metric value within the image. And when it gets that ordered response, as it gates from k-space, it infers the heart rate from that, and then gates all the data accordingly. So once you've worked out the heart rate, you can then apply you can apply that to various different types of sequence. And I think what they've published most widely on certainly is phase contrast. So this would be regarded as the kind of gold standard in postnatal imaging for measuring flow in vessels. And you can see on the left here, this is a fetal descending aorta, which is pulsatile here. This region of interest has been drawn there, and then you've got a beautiful flow curve, which is throughout the cardiac cycle, and you can calculate the flow rate here in mils per second or mils per minute. And they've published very widely using this technique in fetal life. And if I just put up this is their image in the middle here, showing the distribution of the cardiac output in a fetus. Each of the numbers here represents percentage. So you have right ventricular output of 56% of the cardiac output, LV is 41%, and then they assume 3% for the coronaries. And then you can see how the blood is distributed to the fetal brain, lungs, and placenta. And then the diagram on the left is just to show a comparison, if you like, to the forebearer of that type of analysis, which is from Abraham Rudolph's work in fetal lambs. And that was obviously performed invasively, and really is the sort of fundamental building blocks of our understanding of the fetal circulation. So that being able to do that non-invasively in human fetuses in health and diseases has been extremely interesting. We've adopted that method here. We've been doing that since about 2016, and this is just the work we published last year looking at what I'm sure many are familiar with as a very, very difficult diagnosis, prenatally coarctation of the aorta. Difficult in that we often overdiagnose that condition for reasons we don't really understand. So this is just looking at the distribution of the circulation in normal cases on the left, in the so-called false positive cases assumed to or thought to have a risk of coarctation prenatally that did not end up needing any neonatal intervention. and then cases who didn't have intervention on the right. And just to show the application of this in essentially a sort of research setting, but I think potentially lending itself to some clinical understanding too. You can see that on the right, we had reduced flow through the left heart, and we had net reversal of flow at the isthmus. But actually the false positive group also had quite significant changes in the fetal circulation to normal. So perhaps this starts to help us understand or explain why this group is false positive. This is not a normal group. There are changes here for reasons we don't understand, and that's raises a lot of additional questions and is a very active work stream within our department. And we've combined that. So we've combined that with the three-dimensional imaging, and in the same publication, we showed that actually those changes in underlying flow patterns were very strongly associated with change in the geometry of the interface between the aortic isthmus and the duct. And that was in turn very closely related to an increased risk of developing coarctation of the aorta when the duct closes in postnatal life. So a combination of these techniques potentially additive in a clinical sense, so we may help us actually risk stratify, and now we do actually apply this clinically in our cases of coarctation of the aorta, but also bringing a sort of more fundamental physiological understanding of what may be happening in these types of cases, and ultimately it makes it ask more questions perhaps, but really moves that forward, I think. So just moving on from that, and again, this is from the team in Mike Seed's group in Toronto, and just sort of thinking of sort of technical approaches. So in this case, they've used T1 and T2 mapping methods using MRI to estimate both the oxygen content of fetal blood and the hematocrit. And from that, you can actually estimate the fetal saturations in each of the vessels which you measure, fetal oxygen saturations. So this tends to be reserved for late gestation fetuses. I think it needs larger vessels essentially to be accurate. But you can see now you're adding in not just those diagrams looking at the output of the circulation across a range of forms of congenital heart disease and fetal life, but actually looking at oxygen content in the major vessels. And particularly interesting, I think, is oxygen delivery to the brain. And I think this is a very active area within fetal cardiology, people looking at brain development and the implications of congenital heart disease on fetal oxygen delivery, substrate delivery, and subsequent brain development. Obviously, we know there is a very high burden of neurodevelopmental impairments in many of our children with congenital heart disease, and that may have its origins in the womb, certainly. And in cases like transposition, where you have essentially restrictive septum in utero and the changes in oxygenation to blood flow to the lungs. So another sort of facet of prenatal MRI, which is fascinating and really enlightening. And then the final thing, just to say about metric optimized gating, just to go back to that, not just for phase contrast, this is the same team in Toronto, but this is a stack of Cine. So this is sort of similar to what you might see in an echocardiogram, slices through in a transverse stack. And this has actually been retrospectively gated with metric optimized gating. So that particular method has various applications within MRI. Okay, so I'll move on just to the last couple of things. So ultrasound duplicating is another way we can particularly gate the fetal heart during MRI. And this device, I think, is becoming far more widespread now. This has been around for a little while, and it's been developed by a company called North Medical, who work out of Hamburg and are led by Fabian Cording, and work very closely with the fetal cardiology team in Hamburg. Essentially, this is a Doppler device which sits on the maternal abdomen, similar to a sort of CTG monitoring device, but you strap it on there. It uses Doppler, ultrasound Doppler, to point at the fetal heart and get a heart rate, and then it interfaces directly wirelessly with your scanner. So you get the fetal heart rate directly through into your control room, and you can pick any of the sequences you like, essentially off the shelf, and run them straight off the bat gated to the fetal heart rate. It's obviously MR safe and potentially a very neat solution to just getting straight in and doing fetal MRI. That team has published using gated sequences just to freeze fetal motion and get high resolution clips of the great vessels. And other groups have also looked at even just taking standard 4D flow sequences, but because you can gate them, actually getting these sort of beautiful images of flow through the heart. It doesn't offer at the moment any component of motion correction, so you're still relying on a relatively quiescent fetus, which probably means later gestation, but certainly it seems to solve that problem of gating very effectively. And then the final thing I was just going to touch on just from a technical perspective is image-based gating. So metric optimized gating obviously gates from case-based data. For those familiar with MRI, so it essentially takes the raw data, gates that into something that you can then try and infer the heart rate from. This is actually just looking at the images, and this is some work that we developed here and again in King's, essentially taking overlapping stacks of cine sequences. So the heart is moving in these images. And then from those, inferring the heart rate from the images, masking out the heart, and then looking at the changes in the image metric to tell us what the fetal heart rate is, binning all of the different images into different phases of the cardiac cycle, and then reconstructing them in 3 dimensions using very similar techniques to the static 3D reconstruction. This is just, I'm going just straight to the segmentation of some of that data. So this is what this looks like. If you think of the static 3D images I had before, we now have dynamic information here. And this is in a fetus at about 32 weeks. In fact, the fetus had aortic atresia with VSD, which is why the anatomy is not normal here. And you can see, so this is the blood pool, which is rendered. So you can see the ventricular septal defect. You can't see any vessels in this case leaving the left ventricle. But this was acquired at 32 weeks with no cardiac gating in a non-sedated, non-moving fetus. It's a mobile fetus. So reconstructing this data, I think, from all of that overlapping data, as you can see, gives quite a rich data set considering the simplicity, if you like, of the input data. And you could actually acquire those stacks completely agnostically. You don't necessarily have to plan anything, just as long as you're acquiring overlapping stacks, it could be reconstructed to this. From the same data, these use balanced cine sequences. So actually from the exact same input stacks that we created the last image, because there's inflowing blood into each of these sequences that will have a change in phase as it moves through the sequence, you couldn't infer anything from that in a single 2-dimensional sequence, but because we solve this in 3 dimensions to produce those 3D data sets, you can actually solve the phase shift in 3 dimensions for each of the voxels as well. And that means we can essentially derive 4D flow patterns from this non-gated data too. And I think this is potentially something very exciting. We can measure flows as demonstrated in these pictures in the center here, but also start looking at streaming and flow patterns, again, in non-gated agnostic type acquisition. This is all done in post-processing, albeit at the moment rather labor intensive and quite sort of clunky engineering pipelines to get here, but potentially something very exciting for the future. Okay, so I think from there, I thought I'd just round up with some sort of honest limitations of what we, that's what we can do with fetal cardiogram, what we can't do, and what are the sort of ongoing areas which are difficult. Pretty much everything I've shown you has been beyond 30 weeks, and the fetus is going to be bigger beyond 30 weeks, and it's going to be less motion, so it makes life a little bit easier. Obviously, there are major clinical reasons why earlier gestational imaging would be valuable. And I think that's something which is, there are potential solutions for, which I'll talk about, but I think is currently a limitation of the technology really across the board. Extreme fetal movement, which sort of speaks to the first point there, I think in smaller fetuses, there's just more capacity for motion, but that can be difficult to deal with. Very small vessels for obvious reasons. And poor signal, so often MRI is put forward as an adjunct to ultrasound where in mothers who have a very high BMI, for example, or difficult views. I think that's certainly true, although it's worth saying that MRI will still suffer if the woman is very large, for example, or there's difficult signal. That still has implications for MRI as well as ultrasound. So this is just a little bit of like potential solution to those problems. So this is some work again from colleagues here at King's, but this essentially uses a kind of additional step in the reconstruction. So on the right, you can see the type of reconstructions I've already shown you. There's black blood reconstructions with a segmentation of the fetal heart, but this is actually at less than 23 weeks. And the reason we were able to do that is because although the fetus was moving a lot during the acquisition, there's an AI step where we can actually identify organs and sort of do a pre-registration step, align everything roughly in space before we then take it forward and run our usual pipelines. And this, as I said, has been informed by AI methods to identify organs in the 2D data beforehand. And I think that seems to be very promising, particularly for early gestation. This, if you look on the bottom right here, if you compare the top right panel, sorry, I can't point, but if you look at the top right panel and the bottom right panel, this is the standard reconstruction on the top right here. And on the bottom right, we're looking at a non-rigid slice volume registration. So an adaptation of that technique, which essentially allows for some change in the geometry, change in motion, either from fetal breathing motion or movement of the diaphragm, or the fact that the vessels are pulsatile, and just putting that into the equation. And we found already that that's a much more robust extension of that technique, which is certainly better for small vessels and things where you really want to be very precise in your reconstructions. This work is just looking at automatic segmentation. So this is another thing potentially quite time consuming to go out and segment the heart, certainly manually from that data, but could potentially pull that out automatically. So we already have pipelines where you can just take the 2D data, automatically run the reconstruction with AI informed reconstruction algorithms, and then potentially go ahead and just segment that straight away. And I think this really speaks certainly to work streams and making them more efficient, but also reproducibility. So if you start analyzing these data, we're looking at geometrical changes, differences in size between one vessel and another, having automated pipelines to produce that data, I think is potentially very valuable. And then my very final slides, hopefully I'll be to time. So this is really just thinking from a technical perspective, but also more broadly about what else we can do with fetal cardiac MRI and what else we should be thinking about, particularly in our cases with fetal congenital heart disease. So on the left, we're looking at some placental imaging. This is T2 star placental imaging. So if you like functional MRI imaging of the placenta. And we've already published some work, which is amongst others, to show that you can detect quite a range of placental abnormalities in fetuses with congenital heart disease. This is already known. This is already known from histology and from other measures, but I think it's another way that we can really measure that in a lot of detail. And again, this is a very active work stream with us. We want to try and link up what we're seeing in the fetal heart and all of those metrics we can produce with that, and what's happening in the rest of the whole fetal placental circulation. And this is one aspect of that. And then, of course, I think really important to mention fetal brain development. And these are actually reconstructed fetal brains using a very similar technique. We can look at regional brain analysis, brain growth and development. And I think if you then think about coupling that up with all of the things I've just described, the distribution of flow in the fetal circulation, is there increased or decreased flow to the brain? What are the saturations being delivered to the brain? What's happening in terms of the placental function? Is that related? There's a lot you could get into here about trying to look in the round at fetuses with congenital heart disease and the interactions between the heart, the developing brain, and the placenta. And as I said, these are very active work streams, and I think really important to mention alongside all of the other things that I've said. Final thing is fetal imaging with maternal hyperoxygenation, and I think this is, again, this is very much in a research world for MRI. Conceptually, what the implications of this is that you give maternal oxygen during a scan. That oxygen will cross the placenta, increase the oxygen content in fetal blood. That will drop the pulmonary vascular resistance, increase pulmonary blood flow, and essentially increase the preload to the left ventricle. So it'd be very much of interest in cases of left ventricular hyperplasia, borderline left ventricle, coarctation of the aorta. Does the response of the heart, particularly the left heart and how the left heart fills, is the response to oxygenation predictive or tell you something about the characteristics of the left heart, i.e. this is a non-invasive way of actually testing some of the physiological conditions of the fetal heart. And I think with the tools that you have with MRI, something very interesting to look at. But also depends on central function. There may even be implications for how the brain responds to that increased oxygen may tell you something. So again, very important to think about in the round, and that's something we're very actively doing here too. So just to finish off, perhaps just to parallel that initial slide that I put up in terms of postnatal cardiac MRI, this is the kind of the near future, if not the present, for some of these elements of fetal cardiac MRI, 3D, 4D imaging, flows, volumetric data, and potentially linking through to all the other organ systems as well, and ultimately long-term outcomes and a deeper understanding of what's happening in these babies, so that we can address those for those patients, address them for families as well. And then I was just going to finish on this couple of slides. This is just to say that pretty much everything that I've talked about, metric optimized gating, our reconstruction techniques, they are all open source. They are all available on this repository that we've put together through our SEMR special interest group. They need a little bit of work to implement them. I think some technical expertise, but they're all there. So there's nothing kind of locked down, and they're free to use for everyone who wishes to do so. And that group, if anyone's interested, is part of the Society for Cardiomagnetic Resonance, is a very active group in exploring those technologies and helping disseminate them. And I will stop there.
Thank you so much. A very, very interesting talk, and lots of questions I think will come on the panel. Dr. Silverman, do you have any question to our first speaker before we start?
Sure. Well, that was a tour de force, David. Quite amazing summary of all the workers that's going on in MRI. I just am interested to know, you make it sound very easy for people to access this, but when I asked my own group, which is a fairly sophisticated MRI group, they aren't set up to do a lot of these things. What percentage of MRI groups in fetal cardiology around the world do you think have the same facilities that you have to make all of these measurements?
So I suppose it depends on, I mean, there's a number of factors you need. And I think we work in a unit which has a very strong pediatric cardiac MRI service. So in terms of infrastructure, having the machines and having some ways of doing that, we have that. But it's a different thing to get pregnant women on a scanner. And I think, working in a unit where they do fetal MRI obviously gives you a head start as well from that point of view, and just acquiring the sequences. In terms of the additional support, and I think at the moment, anyone who wanted to start, even if they had infrastructure, even if they had a means of getting women on a scanner and acquiring data, would need some technical support, i.e. engineering support, to get things up and running for some of these post-processing pipelines. The exception may be with the Doppler device, because I think that does interface directly and you could use the sort of off-the-shelf sequences. I think that's the sort of USP of that product. But otherwise, I think things are still in a kind of slightly still in the matrix a little bit. And I think you as a clinician, certainly from my point of view, I'd say I wouldn't be able to do this without the support of the engineering colleagues around me. So I think that varies. In terms of percentage, I couldn't say. I think what I could say is my experience of chairing that SEMR group over the past 2 or 3 years is that I've really seen interest just rocket up. And it's probably sort of interested individuals coming from each of the centers, but I think as it gets more visibility, as you've said, I think there's people out there who say like we want to do this. So I think in that sense, because the more people want to do it, I think that the more these pipelines get more straightforward and more usable. So I think that is all actually going to happen over time.
That's fascinating. I'd like to ask you just one other question. I think that Mike Seed, I've asked him this too, in terms of oxygen, you can make changes in oxygen and measure them. But it seems that, for example, in transposition, that the amount of glucose that is delivered to the brain may be the answer rather than the oxygen. Can you measure metabolites or chemical products like glucose with MRI? Is there any way of doing that?
Not currently in fetal life that I'm aware of.
Answer that as well later.
Yeah, yeah, go ahead, Karim.
Maybe I can talk about that. But in essence, you can use a technique called MR spectroscopy to measure this, but MR spectroscopy is limited by not only spatial resolution, but actually motion. So actually it's something we've wanted to measure desperately. And we've got someone who's doing their PhD just sorting out the issue of motion correction and tracking the fetal brain throughout motion, so you can consistently sample the same area and be confident that what you're measuring is the spectroscopy in that region of interest. So we are still about 3 steps away from being able to do that reliably, but people are working on it. We are, but we are not near anything that we think is reliable.
Well, thank you very much. That was absolutely a spectacular lecture, and I really appreciate your contribution, David.
Thank you. Could you please switch your video on, Kubaran, please? We cannot see you. We enjoyed listening to you.
He's got it on.
Okay, great. David, I have a few questions for you. Now, going to simply, I mean, I would like to, now you are trying to do a moving baby, a moving fetus, right? So, because that was before, that was like a prerequisite that the fetus should not move a lot. Is this correct? Is this where basically, apart from the Doppler, apart from the velocities, emotion, the one that you showed with the VSD and hypoplastic heart, is this now the target? And is it happening?
Absolutely. So yeah, I mean, I think the methods and the reconstructions I've shown you have been in moving fetuses. You can correct for fetal motion after the fact, even though you've acquired a load of images that don't line up on the scanner. Essentially, you can put in post-processing, realign everything to produce those 3D images and 3D images plus time. And I guess the question of is it actually happening is probably going to be covered in Kabiran's talk. I can say that in our program, we have, as of last week, scanned our 500th woman carrying a fetus with congenital heart disease through the MRI scanner, and the majority of those have been clinical referrals to get 3-dimensional information about the fetal heart. So it's certainly happening in our center and very well established using those methods.
So why do you want it to happen? I mean, the limitations are coming with the gestational age. You want to do smaller babies. Babies will move more when they're smaller, and you will have twins and so on. So what is the idea of doing? Of course, we don't want to sedate. I mean, is this the only thing, or you think getting live motion is a key to lots of unanswered questions?
I think I'm going to hand over to Kabiran for that, because I think that's actually the main thrust of his talk will be, how we use these methods in practice and how they are potentially additive. There certainly are hurdles, and it's not, this is not something we can use at every gestational age range. It certainly we can't use for every diagnosis, but those are all works in progress. But I think the real utility of it, I think, I would let Kabiran cover that, because I think that's the major topic of his talk, really.
Okay, thank you. We still have you on till the end of the session, and please allow me to introduce our next speaker, Dr. Kubaran Pushburjah. Is a clinical senior lecturer in pediatric cardiology in the School of Biomedical Engineering and Imaging Science at King's College, London. He's an honorary consultant in pediatric cardiology at Evelina Children's Hospital. His interests are in cardiovascular imaging, echocardiography, 3D cardiography, congenital cardiac MRI, and lots. Welcome, Kubaran, and we're very grateful that you accepted the invitation of Congenital Heart Academy. We're certainly going to learn a lot from you. Thank you.
Thank you for the kind invitation, and I'm delighted to be able to share with you some of our experience. I hope the audio is okay.
Yeah.
Perfect, lovely. So I'm just going to really follow on from David's talk and hopefully answer some of your questions as we go through, and also probably repeat a little bit of what David said, but with a bit more of a clinical emphasis. So as David said, this is the crux of why we're successful as a program, because it's a new technology, and any new technology needs to be able to evolve rapidly. And so the co-location of the engineering and physicist teams with these pregnant mothers within an active fetal cardiology department and fetal maternal medicine unit has been the driving force of this program, I have to say. And to do that in an independent or isolated center would be very challenging. So what we have here is our setup. We do about 2 to 4 cases a week. Most of them are clinical, but we do have an active research program. There's myself and David as the main CMR consultants reporting all of these scans. And we've got 2 fellows who are doing PhDs at the moment. It's within an established fetal MRI infrastructure. We have really developed this on the shoulders of our colleagues who have a large center for the developing brain, where they've been scanning fetuses, fetal brains and bodies for a much longer period and a more mature service than our own, but we were able to add to that. We need, of course, because we're dealing with pregnant mothers, midwifery support, radiographers and admin teams to scan the mothers and book them in. And we also have fabulous contributions by our consultant radiologists, because myself and David report the heart, but remember the fetus is not isolated. So we've got the brain and the body and all the other bits, which are increasingly relevant, as I will show you in the later part of the talk. So this is a team. It's massive, and I haven't included most people. And there are 2 bits in color. You can see the big part, which is the clinical team. Our fetal cardiologists are key, absolutely key to this program. And we have our MRI, our fetal radiologists who have superb expertise, and many of you will know Mary Rutherford for all her work on the developing brain. And we have these amazing engineers. And so these are the people we work with on a day-to-day basis. And really, whenever you have any kind of new technology, many of you would have seen this sort of slide, and hopefully you will work out for yourself, I think, where you think this technology currently sits. And I think for everyone coming new into this, we all come in at a different point. I certainly would like to think that as a service, we're somewhere in here. We're on this inflection point, because I think we know what the plateau of productivity is, but I would like to think that it won't plateau. It would actually continue to escalate, but with a not as steep a slope. So we'll talk about MRI in context, our initial experience, a few clinical application examples, and what the challenges are for prime time. So David's already shown you this, and I spend a lot of my time doing postnatal cardiac MRI, because that is the gold standard for surveillance in children and adults with congenital heart disease, because you can actually look at the heart in so many planes, assess function, parametric imaging of the myocardium, and 3D a whole heart to look at geometry. You can also assess hemodynamics with flows. So extremely powerful. And it is very well established that MR is in the guidelines for the surveillance and management of patients with congenital heart disease in childhood as well as in adult life, but emphasizing the fact that it is multimodality. And the way we see fetal MR is multimodality. But you have to be honest with yourself. With any new technology, what are we really adding? Just because you can do something, is it a good reason to do it? So here you have ultrasound. Everyone does ultrasound. It's cheap, it's freely available, it's very well tolerated by the mother. Look at this picture here. Everyone's smiling. The sonographer's smiling, the mother's smiling, she's quite comfortable, the room is nice and bright, there's a lot of air around them, and we get pretty good images. I mean, all of our diagnoses are made with this. And then we have
okay. We didn't
yes,
have we didn't have any PowerPoint slides before. This is the first one to show.
Oh, really?
Slides. Yeah.
Oh, okay. I apologize for that. So you couldn't see any slides before this?
No, this is the first one.
I thought I could see them. I could see them from here. I don't know if others had that problem, but I could see everything up to this point.
Okay. I apologize.
Can see them all. I've seen all your slides. There must be something wrong with yours.
Might be a lag. Yeah. Okay. I'm going to carry on then.
Yeah,
and of course, if I'm going to put a mother into a scanner, as you can see here, it's a bit of an issue. It's dark. It's potentially claustrophobic. David's already talked about the noise. then of course we can make this safe. And so you can scan safely at a 1.5 Tesla or a 3 Tesla scanner in mothers who are pregnant. But we again need to work out, if I'm going to put someone through a scan of about half an hour to an hour, how is this going to be better to the ultrasound? So the other thing, of course, if you look, you can also, what's really important in these pregnancies with congenital heart disease is that we need to be able to make an early diagnosis, as you can see here in ultrasound, where you can actually impact on decision making, which can be challenging. And so with various ultrasound techniques, you can actually get really beautiful grayscale and color Doppler images. And actually you can see what the AV and VA connections are in a sequential segmental approach to help you make your diagnosis. There are things like superb microvascular imaging, for example, a slide from my colleagues, Vita Zederi, and you can see here very nicely how you can actually have very high frame rates as well and avoid the issues of bleeding of the color Doppler with some of these techniques. So moving on from this, you then start to think, well, what else do we need? And so even in ultrasound, there is a quest to try to get some 3D images, because the 3D images give you a little bit more detail, particularly for things like double outlet right ventricle in this example here, to allow you to assess the potential for routing and better counseling before the baby is born. But stick, which is the technique that was used for those 3D acquisitions, is challenging and has a high attrition of data. And I think that's probably one of the key challenges in terms of why it hasn't really fully taken off. However, things are developing rapidly, and even in ultrasound, you're getting better matrix arrays with the transducers, and with real-time imaging, you're able to produce images like the ones I'm showing you, and your stick acquisition in color Dopplers also starting to show us some really very nice images to help us with our diagnoses. And people are using these kind of data sets to actually produce things like 3D printed hearts. And the other thing that you don't get from MR currently is strain data. And of course, we know that the strain parameters or deformation in the fetal heart can be a pointer of pathology or improve our understanding of the physiology of what's going on. So in terms of trying to improve accuracy, even in large, very sophisticated centers, you do find that the accuracy can be diminished. I mean, they were very harsh on themselves in terms of what they were counting as a failure of diagnoses, because even small defects like a partial anomalous pulmonary vein was included in this. And of course, we have to remember this was the time where the 3-vessel views were not always included in some of the studies, which is now standard. But the main thing that they point out is the lack of 3-dimensional imaging was a really big reason for a lot of these discrepancies. The other thing, of course, in our quest for improvement is the fact that you can't always get to the fetus with ultrasound. And things like oligohydramnios and scar and obesity can be a factor. You've got a large field of view. Of course, there's better spatial soft tissue resolution, and it's independent of fetal lie. But as David pointed out before, if you do have a mother with large maternal habitus, sometimes it can provide a challenge for us in terms of the amount of signal we're able to get reliably for the fetus. So this quest of going from 2D to 3D, this is a fetus. You can see very beautifully a double aortic arch in this example with the use of color Doppler, the right arch, the left arch, and the duct. And we can actually, in this example, show you the MRI, which shows you the right arch, the left arch, and the duct. So you could argue, if you're seeing this beautifully on echo already, why do you need the MRI? Well, these were done in the early stages of our program when we were focusing on patients looking at their vascular abnormalities. But what we find is that sometimes it's not that easy to confirm this, and you may need a 3D image to help you. Printing 3D models from this can also be helpful in terms of explaining the pathology to the parents. So David's already talked a bit about this single slice rapid imaging, and I like to use this example of the hummingbird, because effectively, if you've got a fetus that's moving around quite a lot, a bit like a hummingbird, so small, fast heart rate. If I've got a high-speed camera that takes a picture with high temporal resolution, I will get this beautiful image. If I have slow temporal resolution, I'll get this blurred image. So what we'd like to do is use a single shot image and just snap a picture of the heart. Unfortunately, as you can see here, you can do that if the bird is staying in one place. But here you can see the fetus moving up and down. So the problem that you have with that is that if the fetus doesn't move, you get that beautiful single shot that David was showing you earlier. But if they do move, this will be blurred, a bit like this hummingbird. So you are really looking at trying to acquire an image. If it's no good, you have to take it again. If it's no good, you take it again and you wait. So it becomes very expensive time in the MR scanner if you're really going by luck. If the fetus is still, you do well. If the fetus is not still, you don't do so well. And the different types of images that David talked about before are the black blood images here, where you're looking at the blood vessel in relation, which is black, in relation to the contrast of the lungs, which are full of fluid and therefore appear bright with MR. And then you have these SSFP type sequences where you actually get really nice differentiation of the blood pool, which appears bright, against the myocardium, which appears dark. And that's one of the hallmarks of balanced SSFP sequences. So when we looked at this and we started to look at some of the patients in the very early cohort of our group, quite frankly, yes, you can see an aneurysm portion of the RV, but I could see that on ultrasound. So it didn't really help. So we didn't really encourage those referrals after the first cohort of patients that came through. But we were starting to see this beautiful definition of the vessels like the one David showed you. This is a patient with coarctation, and this is a patient with very abnormal pulmonary veins in a patient with the hypoplastic left heart syndrome. I remember being at the time with Professor Razavi, being very excited about this image. We were like, wow, we can see coarctation, but can you? This is a single slice. We're slightly angle dependent. I could be foreshortening something. So in retrospect, probably not the best. So we stopped, obviously, when we started this program. And like any good program, you should always look at your results and see where you're going. And with the 2D approach, we were losing 14% of data. So that, to us, was unacceptable. If you're going to put a mother through an MRI scan, you really need to have a much better success rate of saying to the mother, if you go through this scan, the chances of us giving you useful data is going to be much higher than that. And if you look at the cohort of patients reported from Shanghai, again, using 2D techniques, it wasn't really particularly successful. And so what we've done, and David has talked to you about the technique, and I'll talk to you about the clinical application, is to basically take multiple single shot slices across the fetus, as you will hopefully start to see from the images here. And this is done in the scanner, and we take multiple orthogonal slices through the fetus. And you can see how even if the fetus doesn't move, you still have the issue of maternal respiratory motion, for example. And maternal comfort is really important. So we allow the mothers to have just gentle free breathing throughout the scan. And once we get that sort of image, as you can see here, in terms of raw data, we create a mask and we apply a post-processing technique. And this is what we start to get. We get a 3D whole heart data. This is using the black blood images, so you don't see the intracardiac anatomy particularly well on these images, but you do beautifully start to see how, using a multiplanar reformat, you can go through each of the vessels and start to look at the great vessel arrangements and the branching of the head and neck vessels and details like the pulmonary artery. So these are the sorts of images that you can use not only for clinical evaluation, but really very useful for teaching if you're trying to explain to someone what the 3-vessel view looks like and how that is in relation to the spatial relationships of the other vessels. We're also learning a little bit more about what happens to these fetuses. This is the patient who we, at 32 weeks, detected a double aortic arch with the left duct. After postnatal life, we repeated the scan. This is an MRI scan. And of course, the contrast does not fill a lumen that is atretic. And so this is what we saw. And at surgery, you can see the ligament. So we are able to see obliteration of the native left arch in a double arch. In addition to that, you can actually, when you look at the range of pathologies, and we have a huge range of pathologies that we've scanned over the last few years, even looking at the mirror image branching of the right aortic arch, or in the context of an aberrant left subclavian, or in a double arch, you can start to see the nuances of the arrangement of the great vessels, and suddenly things like the V and the U that people look for become quite easy to explain to people, but again, very helpful in terms of us helping to make a diagnosis. In patients with pulmonary atresia VSD, we're sometimes asked to look to see what the pulmonary arteries look like, particularly to see if we have confluent pulmonary arteries. And the other thing that we're very careful to do is look at postnatal correlation of all of our subjects to make sure that we've got it right. And we collect prospectively all of the data from our patients to see what their outcomes are. But there are limits to this. And I remember, you know, we were getting really good data, and then we got this. This is a patient referred to as pulmonary atresia VSD, and we were asked to look to see if there were confluent branch pulmonary arteries. And this is the data we got. But remember, we're scanning at a spatial resolution of 1.25 millimeters, and there was quite a lot of fetal motion at the time. So we basically got no data that was useful. We couldn't see confluent branch pulmonary arteries, and this is the postnatal CT. But the good thing about that is that it puts us back in our box, because I have to say at this point of the program, we were feeling quite confident. We were saying to the fetal cardiologists, just send them our way, we'll find it for you. And here we failed. So that was another reason for us to stop and think about how we could improve our reconstruction algorithm. And David alluded to that in his talk, and we have better reconstruction algorithms now. In this example here, you can see tetralogy of Fallot with absent pulmonary valve. And now we're starting to move beyond just the heart. So here we've got a heart with, you can see the geometry of the very dilated pulmonary arteries, which is a hallmark of this pathology. But what's really important is looking at the MRI for airway compression. So in the fetal lung, if there's airway compression, you get increased fluid building up in that area, giving you increased signal intensity, which in this same fetus correlates very nicely to the areas of air trapping in postnatal life. So by seeing these lung changes before birth, we're able to stratify these patients that they are more at risk of having significant lung abnormalities, which will mean a prolonged stay on the neonatal unit after birth. The lung volumes are also important, and in the same way that we segment the heart, we can segment the rest of the body, and that includes the lungs. And our colleagues have worked particularly with our obstetric and fetal-maternal medicine colleagues to look at things like lung volume, and our neonatologists find this very useful when they meet with families before the baby is born. In the same way, we get involved with other bits of the patient that go wrong. Patient here with ectopia cordis and abdominoschisis, and you can see here the fetal lung volumes are very low. Moving on a little bit from just being cardiac centric, this is a patient here where my colleagues in fetal cardiology have detected atrial septal restriction in hyperplastic left heart, which is a problem. So is this going to be bad for the fetus? Well, they, in their clinical program, use maternal hyperoxygenation to assess what the pulsatility index is. That's looking at the peak and lowest value divided by the mean velocity to give you a pulsatility index. And here you can see in response to oxygen, the pulsatility index has fallen, causing this to be a bit more favorable for the patient. And in other cases, of course, we would do that plus an MRI. And in this case, this patient has hyperplastic left heart syndrome with TAPVD. We can see in yellow the TAPVD with the level of obstruction of the veins. So these veins are obstructed, and in the same features, you have pulmonary lymphangiectasia. We're also able to calculate flows, which I'll come to later on. And this patient also had diminished pulmonary blood flow. So 3D imaging, functional imaging in terms of flow, and the sequelae of that being pulmonary lymphangiectasia was very helpful to my fetal cardiology colleagues who were able to look at that with the ultrasound and counsel the family. And this issue of pulmonary lymphangiectasia has been looked at by the group at Philadelphia, who've reported initially in 2016 in a cohort of fetuses demonstrating that they do really quite badly. They followed up with a more extensive publication looking at 53 patients who had pulmonary lymphangiectasia, and the risk is still significantly higher in patients who had this appearance in fetal life. The other things to then talk about briefly are things like phase contrast imaging that David talked about before, where we're able to measure flow in the fetus. But the thing to say with that is that you have to define the plane of imaging orthogonal to the vessel of interest. And so if the baby's quite still, that's great. But if they start to move, your images can get blurry. We, with Alex Schultz, who was with us from Germany for several months, looked at our own data and found really quite good inter-class correlation between our two observers. But we did find that some of these flows did need to be repeated. And that's because we would see a degree of motion during the scan. And we created what we've now published as a scoring visual score to allow us to very quickly work out if you had a poor visual score, there is absolutely no point in trying to spend your time post-processing the data, which can be a bit labor intensive. So you're focusing your energy on good data. The Doppler ultrasound gating that David talked about is, I think, going to be very interesting because it comes back to what Professor Silverman was saying, you know, how accessible is this? To reconstruct without gating requires quite a lot of expertise. There's simple expertise, but it does require expertise all the same. By applying a Doppler ultrasound device, you can effectively extract the Doppler signal, turn that into an ECG, which the MRI recognizes as an ECG, and therefore gates the sequence. If you have a gated sequence, you can then just effectively use most of the sequences and reconstruction things on your scanners that exist to scan the fetus. So these are the sorts of things that people are producing on a 1.5 or 3 Tesla scanner. But the only thing, as David was saying before, is that the fetus has to be quite still. So if you look at a lot of the published work using a Doppler ultrasound device, they are indeed in later gestation fetuses. And so it comes back to the original question, is how much of an advantage is that to our fetal cardiologists when I'm giving you data in a fetus at late gestation? How much is it going to affect your clinical decision making? This is examples of Cine Imaging. I've talked so much just now about vessels. We haven't talked about intracardiac connections. And this is why we haven't talked about it yet. If your fetus is moving, you might get this. If your fetus doesn't move so much, you can get this sort of stack. And I'll let it play. But you can see how you going through multiple slices of the fetal thorax, and you can start to build a very nice picture with the spatial relationships of the vessels in relation to the heart with time. You can see the bifurcation of the pulmonary arteries, and then you can start to see the intracardiac connections as well, really quite nicely. So again, if you have a still fetus, that's great. So these are 2D images in stacks. And again, using the Doppler ultrasound device, our colleagues in Sweden were able to produce this kind of work and show really good clinical utility in a cohort of patients, albeit at slightly later gestation, again, 31 to 36 weeks. And they published this very successfully, and it's one of the key first bits of data out there that shows the clinical value of fetal MR in a clinical setting. But this is the editorial that came with it. It says, although fetal CMR provides an appealing opportunity for advanced late gestation imaging, fetal echocardiography remains the gold standard for early and accurate in utero diagnosis. And I totally agree with that. We all agree with that. So we then need to think, what is the value? We think this might be the value, that if you can do this, this is on ultrasound, but if I can now try and do the same thing, so 3D whole heart imaging, but with time. So you can now MPR a beating heart and look at things like the size of an interventricular communication in someone with DRV, for example. and start to really unpick some of the stuff in the same way that we do in postnatal life. So if I did this in an older patient for septation, I'd be doing exactly this, and I'd be doing 4D flows in a postnatal patient. So why not in a fetal patient? And the other really key thing I want to finish off is the fact that you have extra cardiac problems in these babies. So it's not a single system problem. And there are increasing numbers of publications coming out. This is a publication by the group in Vienna, who have a long history of scanning fetuses for all abnormalities, and they have recognized a high risk rate of extracardiac abnormalities in their cohort of patients. In a similar way, the group in Arizona have also recently published a high incidence of extracardiac abnormalities in a cohort of 31 fetuses who underwent cardiac MR. In our own experience, we definitely see that, and we have therefore always had independent reporting of the brain and body of all of the fetuses that come through our program, with links into the fetal cardiologist and fetal maternal medicine to make sure that the information is disseminated, particularly where there are incidental findings. So I think these points probably have already been made in my talk. It is critical to emphasize that these are an adjunct to echocardiography. We use cardiac MRI, not in isolation, but like in postnatal life, as a tool in multimodality imaging, so we better understand the fetus. We regularly sit with our fetal cardiologists and go through the data with them, and we discuss these images at our multidisciplinary team meetings with our surgeons and the rest of the team, so everyone is able to not only critique what we're producing, but we're able to iterate and evolve, so we're able to deliver what is clinically useful to the program. The challenges we have, of course, are things like normal values, so we're in early stages. So if I take the simple example of what we understand about flows and normal flow data in a fetus, Mike Seed's group has done tremendous work in this. And this effort of 40 patients with normal data is phenomenal. But that's the comparison. If you look at the size of fetal cardiac outflow tracts, my colleagues here at the Evelina have used data from 8,000 ultrasounds. So we've got a long way to go before we can even calculate things like Z-scores reliably. The other thing is the data processing, and I think that's been touched upon. And there are concerted efforts. I think this GitHub that David talked about is tremendous. The SEMR working group is a small but very collegiate group, and it's a really exciting. I mean, I go to various kind of special interest groups, but I think the fetal CMR one is the best that I've been to, because everyone has a common goal of making this accessible to as many colleagues around the world as possible. And with that spirit, I think this will become a reality in a shorter time than other things have taken in history. You need your high level of expertise from your team. We need to be very careful that we validate, and reproduce each other's work as well. And then once we've done that, we can focus on things like normal values. We do have more reliable ways of estimating fetal weight, so we can do index things to a fetal weight. And we obviously need to work to correlate all of what we're seeing with our postnatal findings, and being honest with ourselves about things that we're missing or falsely diagnosing, because that could be even worse. So this is the future. I think we'll get there. And this is a really exciting field. So I would be very happy to take questions and hope you found this useful.
Thank you so much, Kubran. Beautiful talk and really, really important points to take home from David and Kubran. And the floor is open for discussion now. I have a few questions, but Dr. Silverman, do you have any questions?
I don't. I just think that today's session, Dr. Kubran and David, done an absolutely spectacular job about presenting this data to us. And I mean, when there's always looked to from my point of view, being a John Simpson fan, to all of the support work that seems to come out of his institution. And all I can do is say, that it's a real pleasure to listen to scientists talking about the strengths and weakness of their discipline.
I quite agree, but I do have a few questions. I think just to simulate the session now. You have beautiful points, and I think the future is for MRI. Now, just technically, if we compare fetal 3D imaging to fetal cardiac MRI, well, 3D, they say, is equivalent to 3D echo, is equivalent to cardiac MRI. Now we have 3D cardiac MRI. So what is the use of 3D echo now in comparison to cardiac MRI in postnatal life and equally in prenatal life?
I'm happy to talk about that because in postnatal, I think the main thing about 3D echo is it's quick, right? You stood by the patient, and quite frankly, MRI is expensive. In an ideal world, your gold standard would be 3D MRI. It's no radiation, beautiful 3D data. You can take it away and play with it for as long as you like and reconstruct it. You can have a non-expert acquiring the image, but the data can be interpreted post hoc for any number of opinions by an expert.
And also you have the flow hemodynamics in the cardiac MRI, right?
You do, absolutely. But it is expensive and it takes time. And remember, when we deliver healthcare, we have to be equitable in our delivery of healthcare. So although you can actually say MRI is the gold standard, we have to also chase what we can do with MRI with innovation in ultrasound. And so we shouldn't just accept that MR, I mean, I do MR for a living, but ultrasound needs to catch up, right? We have to chase each other so patients benefit from this. 3D echo is a near point delivered by the bedside, immediate thing that you can get. And actually, I use real-time echo, for example, in some of the babies I see. You don't need the issue of stitch artifact from respiratory motion or anything. A bit of live 3D and a subcostal view helps me sometimes beautifully define a ventricular septal defect in postnatal life without any heavy post-processing. It's immediate. So I'm a big fan of that, but we can't replicate that in fetal life just yet.
You're not competing with 3D MRI, with 3D echo and 3D cardiac MRI. They are completing each other rather than competing with each other. Is this a nice statement to say?
Yeah, I also think they offer slightly different things. David, you've got a comment.
Yeah, I was going to say completely agree with that. I think MRI will never compete with the usability and efficiency and the real-time nature of ultrasound. And I think that's, as Kubiran stressed, I think that is absolutely, these are complementary modalities, and I think the point of use, the point of sort of the patient entry will always be with ultrasound. I think the specific question about 3D echo, I think there certainly are some incredible techniques with 3D echo out there. I think certainly in our experience here, I suppose speaking for us, I think there's a question just about, I guess echocardiography is subject to the same limitations whether it's 2D or 3D. So, in terms of your fetal lie, you've got a much more limited window of acquisition than you do with MRI. The limitations in maternal habitus and gestational age. And I think there's a question about just overall reliability of those methods. And I think, in busy clinics where you want real-time information with ultrasound, I think it just hasn't quite crossed the threshold. My feeling is with those methods, it just hasn't quite crossed the threshold of reproducibility where you can just say, I'm going to use this method, it's going to work, and it's going to tell me what I want enough times out of 10 for me to pick it up every time I see a patient with those types of questions, albeit they're incredible. And I think, again, echo the concept that doesn't by any means mean that those methods aren't valuable, and the development of those methods is certainly not standing still. And we may find that, yeah, absolutely, there's going to be innovations in that area which which do a lot of the stuff that we're doing with MRI. That would be great. You know, as a fetal cardiologist, it would be great if I could get this kind of imaging at the bedside without having to send for an MRI and do post-processing. That would be amazing. So I think that's probably my sort of view on why those methods aren't kind of out there in the same way.
I just wanted to add a little point there in support of your premise there, David. I think that certainly in the recent times, what we have seen reproduced by three-dimensional Doppler color flow imaging in arch anomalies has been quite astounding and excellent. And the technique of ultrasound is not standing still. It's improving all the time, as MRI is. And so the question of what the indication is for doing a particular test will be determined ultimately by developments that occur from basically bioengineers in both MRI and three-dimensional cardiac imaging. And I think that they're constantly changing, and we should be concerned about that. And I think that we should adopt this attitude that you've promulgated, that we look at what's the best current technique for looking at a particular entity. And I think, for example, with vascular rings, the information that I've seen recently published on this is quite astounding in its excellence. So I think things change over time, and it gets stronger and weaker.